Good afternoon, everyone, and thank you so much for joining us today. Before we get started, a couple housekeeping items. Please utilize the chat box for any questions you may have, and we encourage attendees to interact and share comments or questions in the chat while our panelists are presenting. Please also note that this webinar is being recorded and is for informational purposes only. You should consult a professional advisor for specific medical, legal, financial, or other advice. Please take a moment now to carefully review this notice. Lastly, both the recording and slides will be shared in an email following this event. A survey will also be included, and the members of the collaborative encourage you to share your feedback as we continue to plan future events.
And with those out of the way, welcome again to the BHI Collaborative's Overcoming Obstacles series, Sustaining Behavioral Healthcare in Your Practice. I'm Ryan Crowley, Senior Associate for Health Policy with the American College of Physicians. As one of the representatives for the collaborative, I'm pleased to welcome you to our next webinar in our Overcoming Obstacles series. This educational series is part of a suite of ongoing activities by the BHI Collaborative dedicated to equipping physicians with the necessary knowledge to sustain a whole person, integrated, and equitable approach to physical, mental, and behavioral health care in their practices during the current COVID-19 pandemic and beyond. These webinars are a collaborative product of 8 of the nation's leading physician organizations who have come together to help catalyze effective and sustainable integration of behavioral and mental health care into physician practices. With an initial focus on primary care, the collaborative is committed to ensuring a professionally satisfying, sustainable physician practice experience and will continue to act as a trusted partner to help physicians and their practices overcome the obstacles that stand in the way of meeting their patients' behavioral and mental and behavioral health needs. Today's webinar, titled Bolstering Chronic Care Management with Behavioral Health Integration, will help explore how physicians have used behavioral health integration within their practices to improve the management of key chronic conditions and provide whole person care to their patients. At the end of today's discussion, we'll have a Q&A session with our speakers where you can raise any related issues or concerns you may be experiencing in your practice. So without further ado, I'm pleased to introduce our speakers. Today's moderator is Dr. Tom Tape. Dr. Tape is a professor and chief of the Division of General Internal Medicine and vice chair for clinical affairs in the Department of Internal Medicine at the University of Nebraska Medical Center. Beginning in 2008, he has overseen the development of a patient-centered medical home practice in the resident training clinic. Integrated behavioral health plays a key role in the PCMH practice, especially for patients with diabetes, chronic pain disorders, substance use disorder, insomnia, anxiety, and depression. Dr. Tape's research has focused on better understanding how physicians make diagnostic and therapeutic medical decisions. Joining Dr. Tape, we have Drs. Srila Nambudri and Edwin C. Chapman. Dr. Nambudri is an integrative family medicine physician at Heartland Health Centers, a federally qualified health center located in Chicago, Illinois. In addition to her primary care practice, Dr. Nambudri conducts integrated medicine consultations, leads group medical visits, and spearheads an initiative to expand access to diverse healing modalities. She's dedicated to co-creating a vision of compassion-centered, trauma-informed care and social justice. Dr. Chapman is a Washington, D.C. physician specializing in internal and addiction medicine over the last 40 years. Over the past 20 years, he has investigated the complex mix of addiction, undertreated mental illness, infectious diseases, criminal behavior, and chronic diseases. He's a founding member and secretary of the board of directors of the Leadership Council for Healthy Communities, where he is bringing integrated medical care into underserved communities and faith institutions, using both on-site care and virtual care through televideo consultation for social work, nutritional counseling, pharmaceutical reconciliation, as well as psychiatry and primary care. Thank you all for joining us today to discuss this important topic. And with that, I'll turn the discussion over to Dr. Tate.
Thank you, Ryan, for the introductions, and welcome to all of you that are participating in this webinar. I'm going to just take a few minutes to set the stage on why it is so important to integrate behavioral health into traditional medical care practices. Next slide, please. Next slide. So traditionally, the behavioral health system and the medical care system have been quite separate, kind of goes back to the separation of the mind and the body. And also, I think it's important to realize that traditionally, access to behavioral health and mental health care has been limited by stigma, insurance issues, and provider shortages. And in the traditional medical practices, the failure to fully appreciate the role of behavioral health issues has also created problems for optimal care of the patients. We know that there is a frequent co-occurrence of mood disorders and chronic disease and vice versa. We also know that there are patients that have unexplained symptoms that have a fruitless search for a medical etiology that just runs up the cost of care without appreciating the role of behavioral health issues in those unexplained symptoms, and also the role of lifestyle behaviors in chronic disease. So there's a lot of factors, I think, that allow us to think about how to improve the care by bringing these two systems of health together. Next slide, please. So this is not a new concept about mind-body interaction. And in fact, I need to give a shout out to one of my mentors from my fellowship back in the early 80s, Dr. George Engel, who introduced the biopsychosocial model back in 1977. And I'd like to read this brief quote from his seminal article, which was actually not published in a medical journal where this sort of approach at the time was not well accepted, but it was published in the journal Science. Dr. Engel said, by obliging ourselves to think of patients with diabetes, a somatic disease, and with schizophrenia, a mental disease, in exactly the same terms, we will see more clearly how inclusion of somatic and psychosocial factors is indispensable for both, or more pointedly, how concentration on the biomedical and the exclusion of the psychosocial distorts perspectives and even interferes with patient care. So there have been multiple calls for more of a focus on behavioral health integration in the more recent years, including from the Institute of Medicine, Agency for Healthcare Research and Quality, and World Health Organizations. Next slide, please. So you can think about various levels of behavioral health integration, and sort of here are three very broad, high-level ways to think about it. You can have a system of coordinated care where the two entities are in separate practices, but exchange information, have referral relationships. You can have co-located care where you bring the two practices under one roof, and so patients can come to one location and see both types of providers, kind of one-stop shopping. But what we're really going for is the fully integrated care system, the one that I enjoy in my practice, where the behavioral health and physical health clinicians work together and act together with a joint patient care plan. Next slide, please. So to talk a little bit about the benefits of integrated behavioral health, there's obviously improved access to care, but there's also improved quality of care by considering the patient as a whole. And if you take the societal perspective, it reduces the cost of care. In a fairly recent review of 94 randomized trials of integrated behavioral health, they were able to demonstrate improvements in depression, anxiety, quality of life, and patient satisfaction. There have also been two fairly recent studies looking at the treatment of depression in patients with coronary disease and diabetes, two very common chronic conditions, and demonstrated lower overall total healthcare costs. Next slide, please. Next slide. Great. So I wanted to end up here with calling your attention to this recent report issued last month from the Bipartisan Policy Center entitled Tackling America's Mental Health and Addiction Crisis Through Primary Care Integration. This goes into much more detail than we'll have time to cover today, and I provided a web link to it at the bottom of the slide. Next, please. So now I'm going to turn to our two deep dives into different but important real-world examples of behavioral health integration in chronic care. And so to lead us off, I'm going to turn things over to Dr. Chapman.
Thank you, Dr. Tate. As the introduction pointed out, I do addiction medicine and currently have 230 opioid addicted patients in my practice. Next slide. And as you can see, the opioid epidemic is overwhelming the country. And in this particular slide, we show the impact of synthetics now traversing pretty much the entire nation. The East Coast was particularly affected by synthetics in the form of fentanyl and fentanyl analogs, but now that epidemic of fentanyl is supplanting the pill epidemic and spreading nationwide. So we can see over 50% of the deaths in a number of states in the past year were related to synthetics. Next slide. And this simply shows the impact of COVID last year with Washington, D.C. Leading the nation with a 60% increase year over year from 2019. Next slide. And this simply shows the impact of COVID on the opioid epidemic in Washington. In 2017 and 2019 were our peak years at 281 with a per capita impact of 39 per 100,000. But in 2020, that rose to 58 per 100,000. Next slide. And you can see that in 2016, about 20% of the overdose deaths were related to fentanyl. Now it's 94 to 95% in Washington, D.C. 80% of the deaths are in African Americans, even though African Americans only account for 46% of the population. Next slide. And we can also see that our overdose deaths are predominantly in older African Americans, and this is because our epidemic started with heroin in the 1960s and 70s in the Vietnam era, and in about 2015 we started seeing fentanyl in that same age group. So our deaths are predominantly in the 59 to 69. 50 to 69 age group, but it's impacting all of the age groups. Next slide. My office is shown here. The red and yellow indicate the highest concentration of overdoses, but that also correlates with the highest concentration of HIV/AIDS, hepatitis C, murder rates, unemployment, etc. Next slide. And we can see again in the District of Columbia, if you divide the city east and west, on the west side, there's a lower incidence. On the east side, with they're predominantly African Americans, there's a very high death rate. Next slide. So we also find that we have a high homeless rate in this population because, again, these are older users from 20, 30, 40 years back. And this population also has high incidence of mental health problems. So my patient population, any way you count it, ranges from 25 to 50% homeless or in unsafe housing. Next slide. Next slide. And that's shown there with a 200% increase. So opioid addiction, as you know, as well as cocaine, was treated with mass incarceration in our community. So now we're faced with reverse engineering and reintegrating this older population. Next slide. So this involves the need to develop innovative ways of handling this population who often struggle with not only homelessness and mental health issues, but also do not have access to technology with computers, home internet, and many times if they have a cell phone, the cell phones have limited minutes. Next slide. So this is the age range of my patient population, and you can see correlates with the age range previously shown. I actually have two 80-year-olds who have been using for over 60 years. Next slide. And this impacts the cost of Medicaid in the District of Columbia. So 22% of the 250,000 Medicaid patients spend 53% of the healthcare dollars. That's an average of $25,000 per year. Next slide. And as we know, buprenorphine is considered to be a major treatment of the three, methadone and Vivitrol, but only 2.7% of our patients have access to buprenorphine. Most, when they get medication-assisted treatment, are referred to methadone clinics. Next slide. Next slide. So we can see that in spite of the 411 deaths last year, it's been fairly consistent that only 9 to 16 patients have even had buprenorphine in their system. And again, when we see methadone, again, the incidence is low. Next slide. So the Federal Register in November, really in an effort to get more providers, nurse practitioners, physicians' assistants to treat, put out this notice. And in it, they noted, next slide, that it costs about $7,500 to treat, to medically treat patients who are who have opioid use disorder. Untreated, the cost, because of the high incidence of AIDS, hepatitis C, and other medical problems, is $42,000. So you can see there's a significant savings. Next slide. And we can see the impact of mental illness. If you look at the blue bars related to all of these chronic diseases on the left-hand side, and then the reddish-orange bar to the right, that if you have both a mental health and substance abuse problem, the cost quadruples for any chronic disease. Next slide. So this is my patient population as of December 2019. At that time, I had about 270 patients. 79 or 80% were opioid free. 39 or 14% were non-compliant and opioid positive. And about 18 or 7% were partially compliant, meaning that they tested positive for some other drug like cocaine or marijuana. Next slide. But the savings, in spite of that, are enormous just from the criminal justice system. If you could imagine an opioid user with a $50 a day heroin addict takes about $150 a day in illegal activity to supply those needs. So when you calculate those savings over 270 patients, 365 days, it comes to about $8 million. Next slide. But there are other costs. So if we consider the medical costs at $42,000 a year, the criminal costs, whether incarcerated or on the street, at $35,000 a year, and the social costs, child care and other needs at $35,000, those total costs come to about $112,000 a year. So even though a person is homeless, and we think that they don't cost the system anything, they're really very expensive. Next slide. Next slide. So we show that, if you could go back one slide. So we show that an untreated patient, again, costs $112,000. A partially treated patient, we can save $52,000. And a patient who is fully compliant, we can actually save about $62,000. Next slide. So we try to match this with a payment model similar to the Ryan White carve-out payment model. Next slide. And you can see that in Ryan White, with bundled payments for housing, medical, and Social Security, that we were very successful in treating a very difficult population. Next slide. Next slide. Next slide. So we tried to apply the same model to the opioid patients on Medicare and Medicaid, adding the judicial system and economic support, as well as social services. Next slide. So this was a study that I participated in with the National Academy of Science. And again, we looked at barriers to care. Next slide. Next slide. And there are about 10 barriers listed. I'm not going to go through all of them, but one of the major barriers is prior authorization, treatment, using medication-assisted treatment. Next slide. And we can see the states, the dark blue states represent states that have gotten rid of prior authorizations. Next slide. Next slide. The District of Columbia has partially removed prior authorizations up to 24 milligrams. But this particular study shows that prior authorizations actually cause an increase in emergency room visits and hospitalizations. So getting rid of prior authorizations paradoxically actually saves money in the long term. Next slide. Next slide. Next slide. And two other issues are really in supplementing the needs for these patients, including peer navigators, social service needs, all of which are generally not paid for by insurance. Next slide. Also, there are restrictions on same-day payments for primary care and mental health services. Next slide. So that means that patients would have to come back for a second visit or a distant visit. So we designed what I would call a hybrid model of treatment using telehealth and in-office treatment. We know that the patients are going to come in at least once a week or once a month if they're completely compliant. So we can then access that patient via televisits with a social worker while the patient is in the office, or peer coach, or provide them primary care in the office, or remote services from a psychiatrist or psychologist, since I am not a psychiatrist. Next slide. Next slide. So this is how we partnered in a collaborative model, which I would call a hybrid model in Dr. Tape's design. We do both in-office and remote services by partnering with other practices, psychiatric practices, or hospital that has a social worker and other services. Next slide. This is simply, by contrast, a boutique practice. It's cash only, where you don't need all of those support services. Next slide. Next slide. Next slide. Next slide. So as we integrate those services, we can see these are some of the issues that patients routinely come to the office with. Next slide. 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 We can also do remote monitoring. Next slide. Next slide. And actually in New Jersey, they are now testing the elimination of prior authorizations and reimbursement for peer navigators. And this is being overseen by Rutgers University. Next slide. So these are the takeaway points. Hopefully we can replace incarceration with medical treatment using law enforcement assisted diversion. We talked about myths and stigma. Again, my practice is a hybrid model of the fully integrated practice using braiding and blending of coordinated care and co-location. We need to remove regulatory barriers, and housing is a necessity, and of course, restructure the payment system. Next slide. So I'm going to turn it over to Dr. Nambudiri, and I'm sure she'll give us more insight into adverse childhood experiences, adverse community environments.
I'll just chime in for a minute and say, if you do have questions for Dr. Chapman, please go ahead and type them into the chat box. And at the end of the two presentations, we'll get back and address questions on both presentations at that time. Thank you. Go ahead, Dr. Nambudiri.
Thank you so much, Dr. Chapman and Dr. Tape. It's lovely to be here with you all this afternoon. My name is Srila Nambudiri. Again, I'm an integrative family medicine physician, and I will be talking to you today about how we integrate behavioral health into primary care. Next slide, please. So I work at Heartland Health Centers, and it's a federally qualified health center, or an FQHC, that's located on the north side of Chicago. And this is a picture of one of our locations, the Devon location. Next slide, please. I'm going to use two terms today that sound very similar. So to prevent any confusion, I'm going to define them for you. And the first one is integrative medicine. So integrative medicine is a whole person approach to health that includes the mind, body, spirit, narrative, and community. It emphasizes the therapeutic relationship between practitioner and patient, and it incorporates diverse healing modalities. The second term is integrated care. So this Dr. Tape beautifully defined for us earlier. And what I mean by this is really fully integrated care that involves close collaboration among primary care and behavioral health clinicians, working together with patients and families to provide patient-centered care. So I'm a family medicine physician that uses an integrative approach when seeing my patients. Next slide. So to illustrate integrative medicine for you, I'm going to use the analogy of a tree with branches of a tree versus the roots of the tree. So in medicine, in standard medicine, generally speaking, we kind of see diagnoses as separate. So if you'll have your problem list and you'll have, GERD and diabetes and eczema and migraines and constipation, as separate on the problem list, and you'll have your assessment and plan underneath. And the analogy is that these are kind of like branches of the tree. So they're separate branches of the tree. And in integrative medicine, we see the diagnoses or the branches as expressions of the roots of the tree. And the roots are things like stress and how, and stressors and how the body responds to stress, and which is highly influenced by trauma, adverse childhood experiences, as well as ongoing traumas, nutrition and food, including our relationship to food, food security, physical activity, sleep, relationships, social connection, like are we isolated? Do we have a community? As well as rest. And I differentiate rest from sleep because to me, rest is like, are you able to rest when you feel like your body needs to rest? Are you able to do things that bring you joy? And so this is the lens that I use when I see patients. And the idea is that if we focus on the roots and address them and strengthen them, then the branches will improve. In the context of knowing the context of my patient's life really helps me to understand them as a whole person, which is essential to be able to help them harness their own resiliency and create change. Next slide. So in order to illustrate the ideas I'm presenting now, I'm going to talk through a patient case. So let's meet Rosa. Next slide. So Rosa is a 45-year-old cisgender woman with hypertension, type 2 diabetes, and chronic low back pain. And she's here for her 3-month diabetes visit. Her A1C is 9, which is up from 7.5. She's also been having some trouble sleeping recently and a flare of her low back pain. So I could have, 5 to 7 patients on my schedule with the same diagnoses around the same age. And while I may use similar medications for them, my approach to them in terms of, lifestyle changes, health behavior would be different, again, because they're different people with different stories. So let's get to know Rosa a little bit more. Next slide. So Rosa is a single mother of 3 children. What brings her joy is singing and spending time with her children. She's an immigrant from Mexico, and most of her family still lives there. So she doesn't have a lot of family support, although she is part of a church community here. She works in domestic work. She has to take about 2 buses to get to work usually. And she lives in an area that's labeled as a food desert. And she also does not have health insurance. So why is this context important to me? Next slide. And why does it matter? Because when speaking about chronic illnesses, we really have to start with the social determinants of health, which I'm sure everyone knows on this call what they are. But to define it, the WHO defines them as non-medical factors that influence health outcomes. So they are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. And, we have health disparities because of inequities in the social determinants of health. And why are there inequities in the social determinants of health? We really have to look at how systems of oppression like racism or xenophobia have shaped historical policy. So in the case of Rosa, for example, who's a domestic worker, she doesn't have labor protections because when labor protections were put into practice in the 1930s, domestic workers, who at the time were primarily Black women and who today are predominantly women of color and immigrant women of color, were excluded from the kind of labor protections that were afforded to other types of workers in this legislation. Next slide. And there are so many more historical examples that have resonance today and ramifications and contribute to these inequities. And I believe it's important for us to know these in medicine because we see its impact and we can advocate for policy changes. Next slide. So how does the social determinants of health actually contribute to chronic illness? So the obvious one that most of us talk about is the built environment or the external environment. If we have less access to resources and less access in general to the things that we know promote good health, and if we are exposed to more things that we know can promote stress and toxins, we're more likely to have chronic illness. But how does the external environment actually impact the internal environment? And by internal environment, I'm referring both psychologically and physiologically. So if you're focused on the primary needs of shelter, safety, food, then there's less time to focus on health and emotional well-being, physical activity, social connection. And if you're trying your absolute best and you're working really hard and you don't have time to really care for yourself, and you're also meeting barrier after barrier after barrier, which happens a lot in poverty, then that could cause you to feel understandably really disempowered and negatively affect the possibilities that you can see for yourself. And this can also contribute to grief and anxiety and depression. So this is very stressful. And in addition to the psychological impact, there is a physiological impact as stress increases over time and contributes to more wear and tear in the body, essentially a more allostatic load. Next slide, please. So let's dive a little bit into stress and trauma. Next slide. So what was Rosa's childhood like? Well, she told us that her older sister died when she was about 8 years old, and it caused a lot of kind of conflict in the family afterwards and distance from her parents. She herself is a survivor of sexual abuse, and she also lives in a larger body and has since she was a child. And so she was bullied a lot, and including by some members of her family, which it definitely impacted her body image and her eating patterns. Next slide. And why specifically am I asking about childhood? Well, as Dr. Chapman had mentioned, because we know from the adverse childhood experiences study and subsequent research that childhood trauma has been shown to have a lasting impact into adulthood, such that the more adverse childhood experiences you have, the more likely you are to have any number of chronic illnesses, ranging from heart disease to autoimmune illness. And this is even when controlling for high-risk behavior. Next slide, please. And ACEs, or adverse childhood experiences, are one aspect of trauma and toxic stress, but there are other forms of stressors that can be ongoing and complex, such as the stressors of being in a marginalized identity in some way. If you're poor, or if you're a Black or Indigenous person, if you're a person of color, and or if you're queer or trans person, or if you're disabled, for example. And this image comes from an article that describes the impact of interpersonal racism. So I'm not talking about structural, interpersonal racism on the allostatic load of African-American people. And what this diagram is showing, very simplified, is that in response to a stressor or threat, in this case, it would be discrimination, the hypothalamic pituitary adrenal axis with the sympathetic nervous system kind of work together to send cascades of stress hormones through the body. And this, to kind of get us ready and for the threat. And this influences metabolic function, like blood pressure, blood glucose, lipids, and it also influences immune function. And in the short term, this is adaptive, and it's a good thing. But in the long term, it's harmful, and it can increase allostatic load, which can contribute to hypertension, diabetes, cardiovascular disease, metabolic syndrome, a lot of the things that we see today. Next slide, please. So what are some of Rosa's current stressors? So making ends meet is really hard for her because she was a domestic worker and doesn't have labor protections. She was out of work and didn't have benefits for a few months during COVID. So that's huge. Having diabetes itself, sometimes we don't think about kind of what it's like to have the experience of having a chronic illness amongst trying to live our life and perhaps taking care of our family. A lot of questions about meaning can come up. Why me? A lot of questions about sadness, maybe grief, a lot of anger. And this is, could be separate from a clinical depression or clinical anxiety. It's just kind of part of having a chronic illness, as well as other stressors that she mentioned. Next slide. And so as we see here, and this quote's by Dr. Anthony Ryan Hatch, bodies don't just exist in social and physical space absent any influence. Bodies are always being influenced by the social context in which they live. Next slide. So with this framework, how would we work with Rosa today? Next slide. So we would use our team. And I'm very grateful and lucky to work at a federally qualified health center where we have lots of different team members and there's a lot of collaboration. And one group of members of this team are behavioral health consultants, or BHCs for short, and they are people with degrees of LCSW or LCPC. And as Dr. Tape had mentioned, they're co-located in each of our clinics. And they're able to do same-day warm handoffs with patients kind of as an extension of the visit. Next slide. So how do we use integrated care when we see Rosa? So again, she's here for her diabetes visit. Her A1C is 9, which is up from 7.5. She's also mentioning this like low back pain flare and trouble sleeping. And so I, as her PCP, I know that I have to understand the context of her life to see what's causing her to be constrained perhaps to make certain choices in order for me to help support her in making choices that would benefit her. And so as a PCP, my role is to ask a series of probing questions to kind of understand what her days are like, what's her schedule like, what's her sleep like, what's her rest like. So we're beginning to explore the context of her life. And in doing so, I'm already modeling what a BHC would, or behavioral health consultant would explore. So she can see in my questions and in my linking her answers to her health, the value of reflecting on her life, on her days, the value of being introspective and potentially envisioning, concrete alternatives for choices she could make. So for example, in Rosa's case, if I just ask, has anything changed? It sounds like there's been a lot of changes in the past 3 months. Can you tell me about that? Or how has work changed for you? Or what's breakfast, lunch, and dinner? Any number of opening questions. And essentially I would get from her that her hours changed at work, that now she has to go in at 5 a.m. so she doesn't get to eat breakfast. And then she doesn't really get to eat a full meal at work. Again, going back to labor protections. And so she gets home at 2 p.m. and she's starving, understandably. And then she eats a big meal and kind of feels bad about it. Additionally, she's a single mother, so she's taking care of her kids. And the only alone time she gets is when they go to bed. So that's when she's kind of on her phone and things like that. And then I can reflect back to her like, wow, that's a big change. Your routine changed a lot. And it totally makes sense that, if you have to ignore your hunger cues for hours, that, and it's like your body's in starvation mode. So when you do get to eat, it makes sense in terms of hunger hormones and things like that, that your brain wants to eat a lot of food and you eat past your fullness at that time. That totally makes sense. So not shaming her, but really, having compassion because I could understand the situation. And then saying, I wonder if we can brainstorm ways that you could possibly get back to, an eating pattern that actually feels good for you. I wonder if we can brainstorm ways for you to maybe get 30 minutes more of sleep, 1 hour of sleep. We have Carrie, she's a behavioral health consultant here. She's part of your care team. She specializes in supporting patients make changes that they want to make to support their health. Would you be open to meeting with her and exploring it for 5 to 10 minutes? So as a PCP, I don't really have time to do the whole scope of this, but I can model the value of having this kind of conversation and really set the stage so that she's receptive to meeting with the BHC. And then because the BHC is co-located, they come in right away, which can minimize stigma and just like difficulty transportation because it's not a separate appointment, it's part of the visit, establish rapport, and they can schedule a follow-up. And the BHC can do a lot more than just information gathering. They also support in coping strategies. Of course, they have lots of skills beyond what I do in terms of that. And they can also refer to community resources like food pantries and legal assistance and things like that. Next slide. And the other huge part of this for me is also I would offer her to attend one of our group medical visits or community classes that support patients in stress reduction, in health promoting behaviors, in education about their illnesses, and most importantly, in social connection and cultivating joy. So many of our group medical visits use the empowerment model, which is coined by Dr. Jeffrey Geller, where the focus of the visit is really on empowering patients through having them build relationships with other participants and the provider, and by trying new things together and succeeding at it together. So there is an educational component because that is really important, but the focus of the group medical visit really is on building relationships and like trying new things, because we know that education alone doesn't necessarily reduce stress, right? And by reducing, so relationship building and kind of cultivating joy, things like that kind of reduce stress. And as Dr. Elizabeth Markle says, when people are feeling despair and when they feel disempowered, again, this impacts health behavior and it also impacts physiology. So we want to cultivate the opposite of that despair, which is joy, hope, inspiration, connection, vitality, as she says. And so we try to have this be kind of the focus of our group, to have people feel really empowered that they can make changes. And this to me is really the purpose of including behavioral health in primary care, because addressing our emotional, our mental, our spiritual well-being is really essential for healing and chronic illness. Next slide. So I just want to thank some people who are really instrumental in bringing this presentation here, as well as people whose ideas I've shared with you today. And thank you all for listening. I'll take it to Dr. Tate.
Thank you so much. Those were two fascinating presentations, and I think they demonstrate very nicely the breadth of possibilities for integrated behavioral health, because focusing on two different problems and yet a lot of commonalities and a lot of demonstrated benefits from integrated behavioral health and medical care. I wanted to turn now to questions, and just a reminder for folks who've been listening to the presentations, go ahead and type your questions in the chat, and I'll get through them sequentially. So the first question for Dr. Chapman goes back to the comments you made about prior authorizations and the effect on ED utilization. And I think what the questioner heard was that if prior authorization is not required, there may be an increase in ED visits. Was that the relationship you characterized?
No, it's just the opposite. I'm sorry if I misspoke. Prior authorizations actually increase ED visits and hospitalizations. These are patients who are very fragile, and if they miss their medicine, then they will likely revert to street drugs. So having to go through the administrative burden of contacting a pharmacist who's never seen the patient and may be out of state making those types of decisions becomes quite burdensome. There are also variations state by state and insurance company by insurance company on dosing limits. Some in the past have capped dosing at 8 milligrams, 16 milligrams, and 24 milligrams. And what we found in our population, either due to genetics or epigenetics, that our patient population with the fentanyl analogs actually do better on dosages of buprenorphine between 24 and 32 milligrams. So it becomes really a burden on the patient and a burden on the provider.
Thank you. And the next question is for Dr. Nambudiri. Do you have rounds with your team to check in on patient progress and behavior changes?
Yeah, great question. Of course, collaboration is so important, especially when you have lots of team members. We don't have, it's not necessarily formalized, but we do, we're again co-located. So a lot of it is just at the end of the day or during lunch kind of thing. I think it's important to be co-located, but also having a relationship with our BHC, really, just like with any workplace, right? That really fosters communication. So it's usually through the EMR now, because we're telemedicine. They're not well, they're starting to come back a few days a week, but a lot of it also is now messaging. We use Microsoft Teams as an organization, so it's kind of using multiple modes, both talking on the phone, in person, Microsoft Teams, flags, and the EMR, but not formalized.
So I'm going to stay with you, and the next question has to do with reimbursement models. Could you talk a little bit about how that works for the behavioral health clinic and also for group visits and community classes?
Yeah, that's also a really good question. So behavioral health consultants, they bill like counseling codes. And then in terms of group medical visits, so the idea behind them is that you can see, 8 to 12 patients in 2 to 3 hours. And so you're meeting your billing. And there is an individual check-in component with the patient, either at the beginning or in the during it or at the very end. And so it is like regular billing, but but you're able to do it because you're seeing multiple patients in that time period. So the benefit is that you're getting more time with the patients, and they're getting more time with you, and they're getting time from each other, more importantly. There's actually in the appendix of the slides that you're going to get, I put a link to something called the Integrated Center for Group Medical Visits that's co-founded by Dr. Geller, who I had mentioned, and they are fantastic. They have virtual and in-person, probably soon-ish, training programs, so you can learn how to do them in terms of facilitation and also billing. And I also linked to another organization that's really great with group medical visits, open source wellness. I would definitely check those out.
And just to piggyback on that, there's another question that's very closely related and asks, what topics do you find are most suitable for group medical visits? What types of medical conditions?
Yeah, honestly, anything. So So I think historically, and I could be wrong with this, but I thought that, there was like diabetic medical visits. So it would kind of be mostly for people with diabetes, but it's since expanded. So there's centering pregnancy, for example, which is a group prenatal care visit model. We do here we have a couple of group medical visits for chronic pain. And so one of them has a component of Tai Chi. It has like a discussion component where you're talking about stress and, nutrition and sleep and things like that. And then they actually get acupuncture. We partner with the Pacific College of Oriental Medicine here in Chicago. So the students come. And so that's one form that we have. We have another one that's all about kind of relationship to food, the diagnosis is right, like hypertension, diabetes, cholesterol, and then, we have some that are a little bit more specific to like depression or anxiety. But there's two kind of, in my understanding of group medical visits, there's sort of two, there's one model that's like structured where it's like 12 weeks, 8 weeks, and you have a curriculum that you follow. And that's a really great model. And then the other model is this drop-in kind of open model where people, come in as they need, and it's kind of more of a drop-in thing, which can be more flexible, I think, for a lot of people. So those are a couple of examples.
Thank you. This is, I think, more of a comment, and it says, this is always such a great idea, but the reality of private practice and payments models always brings us back to earth. We are a private practice and rural health center. Private insurance may not pay for these behavioral health models or behavioral health consultants. So I'll just mention that that's something that does get covered in the paper I mentioned at the end that was published last month by the Ideas, Actions, Results of Behavioral Health Integration Task Force. And I'd encourage people in the audience to take a close look at that. It's about 120 pages, so it does take a bit to get through, but I think there's some really good thoughts and calls for healthcare reform embedded in there. So what are your thoughts about value-based care, and how do you see it becoming the dominant model of care over fee-for-service? It seems that physicians will be more incentivized to prevent patients from acquiring a chronic condition using a value-based model. And I think that's a question maybe we should let Dr. Chapman take the first stab at that, because I think that has a lot to do with the kind of practice that he is overseeing.
So absolutely. And that's really why we brought in the social service component and the criminal justice component, particularly with this patient population. So even with the best of medical care, insurance companies, because these patients are so expensive, will push back. But we know they're what we call wrong pocket savings. Those wrong pocket savings are just those savings that I illustrated in the criminal justice system, but also a patient who ends up in jail with children, those children will end up in foster care. So you have the social service costs. So we really need to work together and remove the silos, the government silos, because most of these costs are covered by the government, whether it's incarceration, child and family services, and the medical costs, and particularly in my patient population, it's 98% Medicare and Medicaid. So really shifting those costs and saving, you have to pay for the support services in order to get the outcomes. And that's really why we are looking at a Ryan White-like model, looking at net savings as opposed to just concentrating on the cost of buprenorphine or the cost of the medical savings. There are other savings, and those savings accrue in other pockets.
And Dr. Chapman, here's another follow-up question for you. Anything as providers we can do to advocate to cut down barriers to addiction medications?
Absolutely. So we start with the very basics. And one of the things that we spend a lot of time on is advocating to community groups, the faith community, public service, because if the public does not understand what we're doing, then it won't happen. But if we can get the community behind, and we've been very successful in educating the community on harm reduction, on the fact that if a patient is not totally abstinent or perfect from day one, that there are still benefits and savings because we're making steps towards some of those issues. Housing is a particularly important issue. We know that housing saves money, but yet we leave people on the street and assume that they want to be there, which is not true. So it makes no sense for me to control somebody's blood pressure, diabetes, the substance abuse, and then put them back on the street because they're going to end up in the hospital with pneumonia or something else. And that's happened. This past winter, one of my patients ended up in George Washington Hospital for a month, and now has been housed in a hotel for the past 3 months, all paid for by the city. That could have been averted.
I think that's an outstanding point and probably a really good place to wrap things up, to think about the fact that with attention to these complex interplays of the social determinants of health and the biopsychosocial factors on the whole patient, we can save money for the system overall and improve the health of our patients. So at this point, I'd like to turn things back to Ryan to wrap things up.
Okay, well, thank you, Dr. Tape, and thank you to the panelists. We're at the end of our time today, but before adjourning, we ask for your valuable feedback in our short event survey. It can be found in the Zoom chat box and will also be sent by email along with a link to the webinar recording and slide deck. Your feedback is greatly appreciated and will help inform future educational sessions and resource development by the collaborative. Our next webinar on addressing the growing concerns in child and adolescent mental health will take place on Thursday, May 20th at 1 p.m. Central Time. Physician experts will share how they have identified behavioral health needs within their patient population and use BHI to provide comprehensive whole person care to their child and adolescent patients within the practice setting. Stay tuned for more details. And please also visit the main Overcoming Obstacles series webpage on the AMA website and the playlist on the AMA's YouTube channel to access all of the previous webinars in this series. Lastly, please check out the collaborative's new resource, the BHI Compendium, which provides a helpful framework for how you can make BHI effective in your practice. So thank you again to today's speakers and to all of you for joining us today. Have a great rest of your day.